So what was the goal? The goal was that during the pandemic, we needed to reserve hospital beds. We needed to reserve staff and supplies for infected patients, and to obviously minimize unnecessary exposure to not only patients, but to staff of those who were already infected with the pandemic. Well, we also realized in putting all this together that most patients with breast cancer are initially treated with surgery. We had years worth of data supporting that delaying surgery with neoadjuvant or upfront treatments with endocrine therapy, abbreviated here as NAE, or chemotherapy, NAC, will not adversely impact survival. That's really critical because we're going to talk a fair amount about the use of neoadjuvant endocrine therapy in estrogen receptor positive patients. And we're also going to be talking about chemotherapy in triple negative patients, and also targeted therapies with the Herceptin family of drugs in HER2 new positive patients. In fact, the standard of care, even without the pandemic, is actually to do neoadjuvant chemotherapy and targeted therapies for either triple negative patients or HER2 new positive patients, because we can help shrink down tumors, even have pathologic disappearance of tumors in breast with those standard of care treatments today, regardless of the pandemic. So we convened a multi-specialized panel of experts with numerous, as I said, teleconferences, discussions, a huge literature review to provide a priority schema for managing these patients. I want you to think of the schema as a triage system. In other words, it's a triage system by setting up priorities with the goals, as we said, to reserve and preserve resources, as well as preventing exposure of staff, et cetera, et cetera. So we ended up with basically priority A, B, and C. And priority A categories are conditions that were immediately life-threatening, clinically unstable, or completely intolerable situation with breast cancer. That's priority A. And in each area that I'll be discussing, surgery, chemotherapy, radiation therapy, et cetera, they'll be organized by these priorities. So the highest priority is priority A. Priority category B is actually probably the majority of patients with breast cancer, that treatment or service cannot be indefinitely delayed beyond 6 to 12 weeks. And most breast cancer patients, as I said, are in this category. And often we would be giving neoadjuvant chemotherapy or neoadjuvant endocrine therapy anyway, but we would make this obviously a higher priority in the middle of the pandemic. And then we will then stratify category B into B1, B2, and B3. Even within this, we have a higher priority, a mid-level priority, and a lower priority. And then finally is category C, for those whose treatment or service can be indefinitely delayed until the pandemic is over without severely impacting outcomes. And as we know, the pandemic is carrying on. For instance, here in the United States right now, we're dealing with an upsurge of the Delta variant of the COVID-19, particularly seen in those people who are not vaccinated. And in the United States, we've just recently surpassed, I think, around 60 to 65% of our population is vaccinated. Our goal was by early July, by our July 4th holiday, to actually have 75% of our population vaccinated. We have not reached that goal. We have certain areas in the United States where the numbers are even barely at 50% of the population that's vaccinated. This is particularly true in southern states in my country. So it's important to remember some really key factors here. And one of them is right here, multidisciplinary. We have known for years that the treatment of breast cancer is really multidisciplinary, meaning that surgical oncologists, medical oncologists, radiation oncologists, physical therapists, pathologists, breast radiologists, all of these people come together as a team in order to normally talk about newly diagnosed cases of breast cancer and to outline standard of care treatment, to talk about research protocols that may be available. This is regardless now of whether there was a pandemic or not. So during our height of our pandemic, these multidisciplinary conferences became teleconferences to review breast cancer patients and to document the category for surgery and or neoadjuvant or adjuvant therapies, and to maintain a close follow-up of these patients to ensure best outcomes. Now, there's an asterisk with this up here and down here, and that is that we're not trying to supersede individual physician judgment or institutional policies and guidelines. As this webinar is going globally, obviously we have different levels of the pandemic around the world. We have very different levels of immunization around the world, with the United States being one of the higher immunized countries on the planet. And we've got priority issues vis-a-vis the level of resources available around the world, regardless of the pandemic. So wherever you are in the world, we want to obviously defer to individual physician judgment or institutional policies or guidelines. All right, so let's begin our focus with this prioritization system on outpatient visits. The majority of outpatient visits can be conducted remotely with telemedicine. And during the height of the pandemic, we're trying to limit in-person visits to minimize patient and provider exposure and risk. But under category A, that's not going to be possible. We may have post-operative patients with potential medical oncology emergencies, such as febrile neutropenia and tractable pain, who need in-person assessment. Excuse me, we may have immediate post-operative patients who are having complications or other issues that would require being seen promptly. Under category B, we should then be evaluating outpatient visits by at least one member of the multidisciplinary team, either in person or remotely. These would involve newly diagnosed breast cancer patients, established patients with new problems, those on intravenous chemotherapy, or patients completing neoadjuvant therapy and preparing for surgery, routine postoperative visits, being evaluated for chemotherapy or radiation therapy. Now, this could end up being the majority of patients depending on where you are in the world. The group that can really be deferred are the routine follow-up for benign or malignant conditions, including those on oral adjuvant agents and those not on active treatment, survivorship visits, or high-risk screening. Those can be deferred until after the pandemic.